Okay, let's unpack this. We are looking at an organ today that, usually just minds its own business. It's sitting quietly in the background, just doing its job.
Right.
But when it gets angry,
Huh.
oh boy, it is a total drama queen.
That is probably the most clinically accurate description of the pancreas I have ever heard. Drama queen is. It's
Yeah.
an understatement.
Right.
When this organ throws a tantrum, it can shut down the entire body.
Exactly. So we are diving deep into the pancreas today. But we aren't just, reading a textbook here. We have something way more interesting.
Okay.
We have a stack of raw, messy, just frantic student notes.
Ah, the best kind.
The best kind. I'm
Nice.
talking scribbles, arrows pointing everywhere, misspelled words like Suchi Social,
I love that.
and drawings that look like they were made at like 3 in the morning right before a final exam.
And honestly, those notes are often the best source material. They cut right through the fluff.
They really do.
When a nursing student is scribbling down, "do not touch" next to a diagram of a tube, you know that's a detail that saves lives. It's the panic that tells you what's truly important.
That's it. The panic tells you what's important. So whether you're a nursing student trying to survive the NCLEX or just someone fascinated by how the body works and, how it breaks, this deep dive is for you.
Mm-hmm.
We're going to decode these scribbles to really understand acute pancreatitis
Yeah.
and this massive, scary surgery called the Whipple.
It is a messy topic, literally and figuratively, but I think the mission here is clarity.
Yeah.
We are going to take these fragmented notes, which cover everything from diet and enzymes to survival rates, and we're going to try and synthesize them into a coherent survival guide.
Survival guide, I like that. So let's start with the big picture before we get into the nitty-gritty of the notes themselves.
Right.
Why is the pancreas such a big deal? I'm seeing a note here that just says 2 jobs with a big circle around it.
Right. Well, to understand any of these notes, you really have to understand the tragedy of the pancreas.
The tragedy of the pancreas.
Yeah. It has 2 main jobs, and they're pretty distinct. First, you have the exocrine function. That's all about digestion. It makes the enzymes that break down your food.
Okay.
Second, you have the endocrine function, and that's all about blood sugar regulation. We're talking insulin and glucagon.
So one side handles the steak dinner, the other side handles the candy bar.
Essentially, yes, ideally. But the whole tragedy arises in how those digestive enzymes are handled.
How so?
The pancreas creates these incredibly potent enzymes, trypsin, lipase, amylase. I mean, these are chemicals designed to dissolve meat and fat. You don't want them dissolving you.
Right. Definitely not.
So normally the pancreas stores them in an inactive form. They're like grenades with the pin still in.
Okay. Good visual.
They travel down the pancreatic duct and they don't pull the pin until they hit the small intestine. That's the safety mechanism.
Got it. So they wait until they're out of the house before they explode.
Exactly. But in acute pancreatitis, for various reasons, that safety mechanism fails. Usually it's a blockage, like a gallstone or toxicity from something like alcohol. And those enzymes get activated early.
Oh.
They activate inside the pancreas.
So it eats itself.
Essentially, yes. It's autodigestion. The organ starts digesting its own cellular tissue.
Yikes.
And that causes massive inflammation, incredible pain, and can lead to system-wide shock. That is the context for every single scribble we are about to look at.
Okay, that definitely raises the stakes. So looking at this first page of notes, there's a huge focus on food, or maybe more accurately, the lack of it. I see a note here written in big letters. Start eating small, frequent meals. And another one that says bland foods.
Yeah.
But before all that, there's a giant underlined NPO.
Right, and that is the absolute core of the rest of the pancreas strategy.
Okay.
I mean, think about it. If the pancreas is eating itself because it's pumping out too many enzymes, what's the most logical first step?
Stop it from pumping out enzymes.
Exactly. You want to shut down the factory. And what turns the factory on? Food. So when that note says, start eating small, frequent meals, that's actually the goal, right? That's not where we start immediately.
Got it. So that's the end game.
Correct. And that is a crucial distinction, especially for exams. Usually these patients start NPO nil per os, nothing by mouth. We starve the pancreas to stop the pain.
You literally starve it.
You do, because every time you even smell food or chew food or swallow it, your vagus nerve sends a signal that stimulates the pancreas. So we have to cut that off completely.
Okay, so we starve the fire, but obviously, humans need to eat eventually.
Of course.
The notes have a kind of timeline here. It looks like it goes from NPO to clear liquids and then to this bland, low-fat diet. Why the emphasis on small meals?
Because a big meal like a cheeseburger and fries is a massive demand on that factory. Large meals cause a huge release of enzymes all at once. For these patients, that equals more pain and more damage. Small meals keep the demand low. It's like we're trying to sneak nutrition in under the radar.
Okay, that makes sense. I see another note here scrawled on the side. Avoid caffeine alcohol. Now, alcohol I get, and I know we're going to talk about that later because it's a huge trigger.
It is.
But why caffeine? Why can't I have my morning coffee if I have pancreatitis?
It all comes back to stimulation. Caffeine is a stimulant, and it stimulates gastric secretions. It increases stomach acid.
Okay.
And when the stomach gets revved up, it sends out these chemical signals, specifically hormones called secretin and cholecystokin, to the pancreas saying, hey, wake up, stuff is happening down here.
And the pancreas screams back, I'm trying to sleep here.
Or, more like, I'm currently on fire, please leave me alone. So, yes, coffee is a villain in this situation. The student's note is spot on.
Wow. Okay, now let's look at the specific foods. The note says bland foods and also mentions low fat in a couple of places. But then we have this image, this picture that's part of the source material.
Ah, I see that.
And it shows all this really healthy stuff, avocados, nuts, olive oil. And there's a big fat X drawn right through it.
Yes. The great irony of nutrition science versus acute pathology.
Right. Because usually we're told avocados are the good fat.
Oh, wow.
We're supposed to be obsessed with healthy fats.
Yeah.
And in this context,
Are they? In the context of acute pancreatitis, absolutely not. This is a classic exam trap question.
okay, explain that.
Fat, and it does not matter if it's from a greasy burger or a beautiful organic avocado fat, is the single most potent stimulator of pancreatic enzyme release.
Really, more than sugar, more than carbs.
Much more. Fat requires the enzyme lipase to break it down. And where is lipase made?
In the pancreas.
In the pancreas. So if you eat fat, your body screams at the pancreas to release lipase. And if your pancreas is inflamed, that release triggers excruciating pain and more inflammation.
So despite that nice picture of healthy foods for a pancreatitis patient, that avocado is basically danger.
It is a chemical weapon in that moment. So the note low fat is a critical safety warning. It isn't about cholesterol or calories. It's about reducing the workload of a critically injured organ.
Wow. Okay, there is this interesting scribble right in the middle of the page. It's a bit hard to read, but it says, if it runs out. And then right near it, bowel tells. I love the phrasing bowel tells.
It sounds like a fortune cookie, doesn't it?
A very specific, very medical fortune cookie. The bowel tells all.
It's true, though.
So what does the student mean here? If it runs out and bowel tells.
I suspect if it runs out is a fragmented thought, maybe about IV fluids or something, but
Yeah.
let's focus on bowel tells. This is the key to advancing the diet. How do we know if a patient can actually handle food after being MPO for days?
You ask them if they're hungry?
Well, that's part of it. But the real objective test is gut function. When the body is in severe pain or shock, the gut often just shuts down. We call it an ileus. The plumbing stops moving.
And if the plumbing isn't working and you put food in,
You get an obstruction, you get vomiting, you make everything so much worse. The tolerance that's mentioned in the notes, that little phrase, if they can tolerate food, is measured by two things: their pain level and what the bowel tells us.
so you're literally listening with a stethoscope.
Exactly. You are listening for Boragimi bowel sounds, gurgles. If the abdomen is silent, that's a big red light. Stop.
Okay.
But if you hear gurgling, or even better, if the patient passes gas, that is the bowel telling you that the system is back online.
It's like a game of red light, green light for digestion.
It is, exactly. And the nurse is the referee. You don't just blindly follow the order to feed the patient. You assess. You listen to what the bowel tells.
Okay, so let's say the red light is on. They can't eat. The bowel tells us to back off.
Yeah, good.
But they still need nutrients, right?
Yeah.
I mean, a person can't run on just IV fluids forever.
Correct. And that leads us perfectly to the alphabet soup that I see in these notes.
Yes. I see TPN with an arrow pointing to central line and then PPN with an arrow to peripheral line. This looks like classic exam material.
This is the bread and butter of nursing school exams, 100%. When the gut can't work, we have to bypass it. We go straight to the blood. That's parenteral nutrition.
Okay, break down the difference for me. TPN versus PPN. Why does one need a central line and the other one is okay for a regular arm IV?
It all comes down to osmolality, which is just a fancy word for how concentrated the fluid is.
Okay.
Think of TPN, total parenteral nutrition, as a thick, heavy sludge of pure nutrients. It is packed with glucose, amino acids, lipids, everything. It's very, very concentrated.
Like a super shake for your veins.
A super shake that is so chemically concentrated, if you tried to put it into a small vein in your arm, a peripheral vein, it would irritate the vessel walls, it triggers chemical phlebitis, it effectively burns the vein from the inside out.
Yikes. Okay, so you need a bigger pipe.
You need a much bigger pipe with much faster flow. A central line goes into a massive vein, usually the superior vena cava, right near the heart. The blood flow there is huge and turbulent, so it dilutes that thick TPN instantly. It's the only safe way to give it.
Got it. So TPN equals big vein, a central line, and PPM.
PPN is parenteral nutrition. It's a much more diluted version. It's not as hot chemically, so it's safe for a regular arm vein. But because it's so diluted, you can't get as many calories in. It's really just a temporary bridge for a few days, maybe. TPN is for the long haul.
Now, there's a check mark here, right next to blood sugars. And I'm looking at this note. The student doesn't mention the patient having diabetes. It just says blood sugars.
This is the classic trap, and I love that the student highlighted it. You absolutely must check blood sugars on a patient receiving TPN, even if they have never had diabetes a day in their life.
Why? Is it because there's sugar in the TPN bag?
There is a ton of sugar in the bag. It's a high concentration of dextrose. You are basically mainlining sugar 24 hours a day. And now, think about our patient.
They have a sick pancreas.
Right. And what does the pancreas do?
It makes insulin.
Exactly. So you have this double whammy. You are flooding the system with sugar from the TPN, and the very organ responsible for producing insulin to manage that sugar might be completely out of order.
So their blood sugar could just skyrocket.
Through the roof. Hyperglycemia is a major, major risk. And what loves sugar? Bacteria. If your blood is full of sugar, your risk of infection and sepsis goes way up.
So the nurse's job is to check the blood sugar. How often?
Usually every 6 hours, sometimes every 4. You check it regularly. Not because the patient is diabetic, but because the treatment itself creates a diabetic-like condition.
That makes perfect sense. And I bet that's a question that trips people up on exams all the time.
100% of the time. Your patient has no history of diabetes and is on TPN. Do you check their AccuChecks? Yes. The answer is always yes. If you don't, it's considered negligence.
Okay, let's move to when they can eat, or at least when we are trying to manage the more chronic side of things. I see a note here about medication. It says enzymes. Take C meals or snacks. The C has a little line over it, which I'm assuming is the medical shorthand for with. Yes. CUM is Latin for with. It's standard charting. And this note is referring to pancreatic enzyme replacement therapy, or PEER, usually a drug like pancrelipase.
So, take with meals or snacks. This seems simple, but the fact that the student wrote it down and underlined it tells me the timing is critical. Why? Can I just take my pills in the morning and then eat lunch later?
Nope. That would be completely useless. This goes back to the concept of creating an artificial pancreas.
Okay.
In chronic pancreatitis, or after some surgeries, the organ has just burned out. It's not making enough enzymes anymore, so we have to replace them with a pill.
Right.
But you have to remember what enzymes do. Their job is to digest food. They work by direct contact. They have to physically mix with the food chyme in the stomach and intestine to break it down.
So if I take the pill on an empty stomach, the capsule dissolves, the enzymes are released, they look around for food, find nothing, and then they're just neutralized by the stomach acid and pass through. They do nothing. Then you eat your meal an hour later, the food goes through, and there is no enzyme there to meet it.
I like the analogy we were talking about earlier, the one about the washing machine.
It's the perfect analogy. Think of the enzymes as laundry detergent, and the food is the dirty clothes. If you pour detergent into an empty washing machine and run the cycle...
Nothing happens.
Right. And then you throw the dirty clothes in afterward.
Your clothes don't get clean.
Exactly. You need the detergent with the clothes. You need the enzymes with the food. Every single time. If you eat a snack, you take an enzyme. If you eat a meal, you take an enzyme.
And how do we know if it's actually working? There's another note here that says, record stool. If they keep having stools, may need increase.
This brings us to the poop indicator.
I knew we'd get there eventually in a GI discussion.
In GI nursing, all roads eventually lead to stool. The clinical term here is steatorrhea.
Steatorrhea. Okay, sounds fancy.
It just means fatty stool. If you don't have enough enzymes, you can't digest fat. So where does that undigested fat go? It passes right through you and ends up in the toilet.
And what does that look like?
It's unmistakable, really. It's voluminous, it's often frothy or greasy, it has a uniquely foul smell, worse than usual, and it floats. Oil floats on water.
Okay, that's a vivid image, but a helpful one.
It's the visual feedback loop for the nurse and the patient. If the patient reports, hey, my poop is floating and it looks oily, the nurse knows immediately. The enzyme dose is too low. We're not digesting the fats. We need to increase the amount of detergent.
So the note, if they keep having stools may need increase, is basically saying, look at the output to titrate the medication dose.
Exactly. It's functional, real-time nursing. You don't need to wait for a lab test. You look at the toilet.
Okay, we've covered diet, we've covered meds. Now we have to go to the dark side of these notes, the complications. There is a list here that just looks like a horror movie trailer.
Oh.
Risk for clots, hypotension, breaths.
This is the danger zone. This is what actually kills people with pancreatitis. It's not the pain itself that kills you. It's the systemic reaction to that inflammation.
Let's start with hypotension. Low blood pressure. Why on earth does an inflamed pancreas in your abdomen drop your blood pressure?
This is a concept called third spacing. It can be a little tricky, but it's absolutely vital to understand.
Okay, walk me through it.
When the pancreas is that inflamed, it releases all these inflammatory mediators, cytokines, things like that. These chemicals circulate throughout the body and they make all your blood vessels very, very leaky. The capillary permeability increases everywhere.
So you have leaky vessels all over your body.
Exactly. So the fluid that's supposed to be inside your veins, the plasma that keeps your blood pressure up, it starts leaking out. It goes into the abdominal cavity, into the tissues. It's rushing to the site of the fire, so to speak, to try and cool it down.
So the fluid literally leaves the bloodstream.
Yes. It moves from the first space, which is the blood vessels, to the third space, which is the surrounding tissues and abdomen. So you can have a patient who looks puffy and swollen, but inside their veins, they're actually empty. They are profoundly dehydrated intravascularly.
And empty veins mean?
Low blood pressure, hypotension, and eventually shock. The heart rate spikes to try and compensate. That's tachycardia. This is why the #1 treatment for acute pancreatitis is massive fluid resuscitation. We have to refill the tank faster than it's leaking.
Wow. Okay. That totally explains the hypotension note. What about breaths? That's a pretty cryptic one. Just the word breaths with a question mark next to it.
That is almost certainly a student shorthand for respiratory distress or ineffective breathing pattern. You have to think about the anatomy. Where does the pancreas live?
In the abdomen, kind of behind the stomach.
Yes, but specifically, it's tucked way back in what's called the retroperitoneum, and the tail of the pancreas sits right up under the left side of the diaphragm.
And the diaphragm is the muscle you use to breathe.
It's the main muscle of respiration.
Oh, I see where this is going.
If you have a raging fire, all that inflammation right underneath your diaphragm, does it feel good to take a deep breath?
No, it probably hurts like crazy.
It's excruciating. So the patient takes tiny, shallow breaths. Little sips of air. They're guarding the area to prevent the pain.
And if you don't take deep breaths,
your lungs don't fully inflate. The little air sacs at the bottom of the lungs, the alveoli, they can collapse. That's called atelectasis.
Okay.
And that inflammatory fluid can literally seep across the inflamed diaphragm into the space around the lungs. That's called a pleural effusion. Both of those things, atelectasis and effusions, they lead to pneumonia and, in the worst cases, respiratory failure.
So breaths is a huge reminder to the nurse. Monitor their breathing, make them use that instead of spirometer, make them cough and breathe deep, even if it hurts.
It is crucial. Acute respiratory distress syndrome, or ARDS, is a leading cause of death in severe pancreatitis. The lungs fail because of the pancreas.
And the third one on this scary list, risk for clots.
Ah, yes, the perfect storm for a DVT. You have systemic inflammation, which naturally makes your blood stickier. The body is in repair mode, so it ramps up all the clotting factors.
And at the same time, the patient is lying in a hospital bed because they're in absolute agony.
Exactly, immobility. So you have stasis of blood in the legs from lying still, plus you have hypercoagulable, sticky blood from the inflammation. That equals clots.
Deep vein thrombosis.
A DVT in the legs, which is bad enough, but it can break off, travel to the lungs, and become a life-threatening pulmonary embolism, a PE.
So things like compression stockings and blood thinners are standard.
Oh, absolutely. Prophylactic heparin or Lovenox injections are standard of care, even if they aren't bleeding. We have to prevent the clots before they form.
It really is a cascade, isn't it? One angry organ just sets off a chain reaction that takes down the whole body.
It's a systemic disease. That's what students often miss. They focus on the belly pain, but the patient dies from shock or lung failure or a PE.
Now, speaking of drastic measures, let's talk about the Whipple. The note says, do a procedure called a Whipple post-op complication. It's written in big, bold, capital letters.
The Whipple, the pancreaticoduodenectomy, even saying the full name is a mouthful.
What is it? It sounds almost whimsical, like a dance or something, but I know it's not.
It is one of the most complex, massive, and high-risk surgeries a human being can undergo. It is usually the Hail Mary procedure for pancreatic cancer that's located in the head of the pancreas.
Okay.
Because pancreatic cancer is so aggressive, you can't just cut out the tumor. You have to take everything around it that it might have touched.
So what? What goes? What do they take?
They remove the head of the pancreas, they take the entire gallbladder, they take the duodenum, which is the first part of the small intestine, they take part of the common bile duct, and sometimes they even take part of the stomach.
Whoa. They basically hollow you out.
They do. And then the really hard part is they have to sew everything back together. They have to replumb your entire upper GI tract. They reconnect the stomach to the intestine, the remaining tail of the pancreas to the intestine, and the bile duct to the intestine. It is a plumbing nightmare.
So the risk of leaks from those new connections must be huge.
It is the single biggest risk. A leak, especially from the pancreatic connection, means those potent digestive enzymes are spilling freely into the abdominal cavity, digesting the sutures, the blood vessels, everything.
That brings us to what might be the most important note on this page. It's a little jumbled, but it says monitor, no test removed for, which I'm interpreting as maintain tubes and don't mess with them. The student has basically circled the drawing of the NG tube.
This is the absolute non-negotiable do not touch rule of post-op nursing care.
Okay.
After a Whipple, the patient comes out of the OR with a nasogastric tube, an NG tube, to keep the stomach empty and decompressed.
And usually if those tubes slip a bit, nurses can adjust them, right?
In a normal patient, yes. If it slips out a few inches, you might gently push it back in. But in a Whipple patient, you never, ever do that.
Why not?
Because the tip of that tube is sitting right inside or right next to that fresh internal stitch line, the anastomosis. If you blindly shove that tube back in, you could poke right through that new connection.
And cause a massive internal leak.
Which would be catastrophic. Peritonitis, sepsis, and very likely death. So the rule is, do not touch. If the tube falls out, you tape it to their cheek and you call the surgeon immediately. You do not reinsert it, period.
That is a high-stakes note, do not touch. I feel like that should be tattooed on the back of the nurse's hand.
It practically is, and it's heavily tested for that exact reason. If you see a question on an exam about a Whipple patient's NV tube, the answer is almost always going to be, do not manipulate it or notify the surgeon.
And there's another note here about bowel tells. Again, specifically monitor output. This applies to the Whipple patient too, right? In a big way.
In a huge way, yes. After a surgery that massive, the gut goes into shock. It just goes to sleep. We call it a paralytic ileus.
The bowel is literally paralyzed.
Temporarily, yes. It stops moving.
Yeah.
So once again, you cannot feed this patient until the bowel wakes up. You are listening for those gurgles. You are waiting for the patient to pass gas. If you feed a sleeping gut, it just backs up and puts pressure on those delicate suture lines.
Hence the NG tube to suck everything out until the gut decides to wake up.
Exactly. It keeps the stomach empty and decompressed to protect those precious stitches.
Okay, we have covered so much of the physical trauma, but there's a very human side to these notes that I want to touch on. I'm looking at the bottom corner, and there's a note that says, dietary restrictions, talk to them about alcohol use. And then right next to it, another one. The psychosocial, do they have support system?
This is the elephant in the room for this disease.
We mentioned earlier that alcohol is a trigger. How big of a trigger are we talking about?
It's the #1 cause of chronic pancreatitis and a massive cause of acute attacks, especially recurring ones. Alcohol acts as a direct toxin to the pancreatic acinar cells. It also creates these little protein plugs that block the tiny ducts, which leads to that whole autodigestion cascade we talked about.
So asking a patient to stop drinking isn't just a lifestyle tip. It's a critical medical necessity.
It is literally a matter of life and death. If they continue to drink, the pancreas will continue to destroy itself. It leads to intractable chronic pain, malnutrition because they can't digest food, and eventually diabetes.
But that's such a hard conversation, right? The note just says, talk to them about alcohol use. That's not an easy 5-minute chat.
No, and the note is right to imply that the nurse has to initiate it. It's not about judgment. You can't just walk in and say, you're a drunk, you need to stop. You have to explain the mechanism.
Yeah.
You have to say, the alcohol you drink is directly flipping a switch that causes this organ to burn itself. We have to turn off that switch. You have to make them understand the direct physiological link.
And that leads right into the psychosocial note. Do they have a support system? Why is that specifically flagged for this condition?
Because recovering from pancreatitis, or God forbid, living with the chronic version, is exhausting. The pain is debilitating. The diet changes are socially isolating. Imagine going out with friends and you can't have a drink, you can't have anything with fat, you can only eat a tiny meal. It's very hard.
Yeah.
If you don't have a support system family, AA, friends who get it, the relapse rate for alcohol use is astronomical. And the depression rates are very high.
It takes a village to save a pancreas.
It really, really does. Pain management alone is a huge burden. These patients often face stigma because they need high doses of opioids to control the pain, and people, even in healthcare, can assume they are just drug-seeking. A good support system advocates for them.
There's one last note here that is pretty grim. It's just scrolled near the Whipple section, and it says, 5-year survival rate.
Yeah. That is the harsh reality of pancreatic cancer. It's often called the silent killer because by the time you feel symptoms, by the time the angry organs start shouting, it has often already spread to other organs. It's usually caught very late.
So the survival rate is low.
It is very low. The 5-year survival rate has historically been in the single digits, though it is improving slightly with new therapies. That scribble is a stark reminder that for many of these patients, especially the ones getting a Whipple, we aren't always talking about a cure. We are often talking about palliative care.
Right.
Symptom management, making the time they have left as comfortable and meaningful as possible.
That really puts the whole bland food and small meals thing into a different perspective. It's not just about healing, it's about quality of life.
Exactly. If we can stop the pain, if we can help them digest enough food so they don't starve to death, we are giving them quality of life. That is the essence of the nurse's job.
Well, that was a heavy but incredible journey through these scribbles. Who knew a few messy pages of notes could contain so much human drama?
The body is dramatic. The pancreas is just the loudest actor on the stage when things go really wrong.
So let's wrap this up. We promised a survival guide summary. Let's do a rapid-fire recap of the key takeaways for anyone listening who needs to memorize this, especially those nursing students sweating over the NCLEX.
Okay, let's do it. Fire away.
Number 1, diet.
Start NPO. Rest the organ. When you advance, go slow. Clear liquids, then blend low fat. Small, frequent meals. Remember, fat is the enemy because it triggers lipase.
Number 2, meds.
Enzymes, pincrelipase. They must be taken with every single meal and snack, no exceptions. And watch the stool. If it floats and smells foul, that's steatorrhea, and you need a higher dose.
Number 3, the alphabet soup lines, TPN and PPN.
TPN goes in a central line because it's too harsh for small veins. PPN can go in a peripheral line. And always, always, always check blood sugars every 6 hours on TPN because of the dextrose load, even in non-diabetics. That's a huge safety point.
Number 4, the Whipple procedure.
Post-op care is key. Monitor the NG tube, but do not manipulate it. If it moves, call the surgeon. And listen for bowel sounds. The bowel tells. Before you even think about starting to feed them.
And finally, number 5, safety and the big complications.
Watch for hypotension, which is caused by that third spacing fluid shift. Watch for respiratory distress caused by the pancreas irritating the diaphragm. And watch for clots from inflammation and immobility. Shock, lungs, clots.
Boom. There it is. Your cheat sheet to the angry organ.
And just remember, behind all those tubes and rules and lab values is a person in a tremendous amount of pain.
That's the most important part.
Yeah.
And before we sign off, I want to leave you with one final thought. We talk about the pancreas being hidden and silent until it's too late. The student's notes mentioned it's like an ulcer. Pain is the great communicator.
It really is. We so often ignore the whispers from our bodies until they have to scream at us.
So when you look at these scribbles, or when you're studying for that exam, don't just see a diagram of a duct. See the human being behind the diagnosis. Someone who is scared, someone who is in pain, someone needing careful nutrition, and just as importantly, psychological support. That's what makes a great nurse, and frankly, a great learner.
Well said.
Thanks for diving deep with us today. We'll see you on the next one.
Take care.